How to treat and cure fungal sinusitis. Fungal sinusitis is the inflammation of the lining mucosa of the paranasal sinuses. It occurs in people with reduced immunity. The maxillary sinus is the most commonly involved. Fungus responsible are Aspergillus fumigatus, 90%, Aspergillus flavus and Aspergillus niger. Fungal sinusitis occurs most commonly in middle-aged populations. Diabetes mellitus is the most common risk factor involved. Sinusitis or sinus infection is inflammation of the air cavities within the passages of the nose. Sinusitis can be caused by infection, allergies, and chemical or particulate irritation of the sinuses. Most people do not spread sinus infections to other people. Sinusitis may be classified as acute sinus infection, subacute sinus infection, chronic sinus infection, infected sinusitis, and non-infectious sinusitis. Symptoms of a bacterial sinus infection include facial pain, pus-like nasal discharge, and symptoms that persist for longer than a week and that are not responding to over-the-counter, OTC, nasal medications. Sinus infection is generally diagnosed based on the patient history and physical examination. Bacterial sinusitis is usually treated with antibiotics. Early treatment of allergic sinusitis may prevent secondary bacterial sinus infections. Home remedies for sinusitis and sinus infections include over-the-counter, OTC, medications such as acetaminophen, Tylenol and others, decongestants, and mucolytics. Nasal irrigation can be accomplished with a nati pot or rinse kit, nasal bidet. Invasive invasion occurs in the host tissue. Acute fulminant. Chronic invasive. Granulomatous. Non-invasive, fungus stays extramucosal without invading host tissue. Saprophytic infection. Sinus fungal ball. Allergic fungal sinusitis. Patient mostly presents with fever of unknown origin. Early features include facial pain and pain around the eyes, nasal congestion, rhinorrhea, running nose, headache. Later there may occur a loss of vision, ophthalmoplegia, paralysis of ocular muscles, proptosis, forward bulging of eyeballs, change in mental status, and seizures. Acute fulminant form, the fungus invades into vessels causing thrombosis, necrosis with minimum inflammation and no granuloma. Chronic invasive, fungal hyphae invades tissue leaving necrosis with minimal inflammation and no granuloma. Granulomatous form, invasive hyphae invades tissue with inflammation and multinucleate giant cell granuloma. Saprophytic infection, growth of fungus seen on mucous crusts within sinus cavity. Sinus fungal ball, sequestration of fungal hyphae as densely tangled, concentrically arranged masses in the sinus cavity. Allergic fungal sinusitis, the protein component of fungus elicits IgE-mediated allergic mucosal inflammation. History and clinical examination gives an idea about fungal sinusitis. However, microscopy with Giemsa or Kalkoffler white stain or culture with Saber-Odsager of the material confirms the diagnosis. Co-mount is also helpful in diagnosing fungal infection. Indication for imaging. Suggestive clinical features, multiple recurrent episodes, persistent pathology, failed conservative treatment, minimal relief by conventional therapy, relief only after steroid therapy. Plain X-ray nose and paranasal sinus waters view, homogeneous opacity with areas of increased density and dense circumscribed shadow, bony destruction, sclerosis of sinus walls, calcification in the opacity. CT, scan nose and paranasal sinuses axial and coronal view. CT scan can document the presence of sinusitis, and demonstrate which sinus can be addressed surgically. More subtle signs suggesting diagnosis are unilateral nasal edema or single sinus inflammation. MRI used to find the intracranial extent of the disease, to evaluate patients who demonstrate signs of intracranial invasion such as change in mental status, seizures or stroke. Systemic antifungals, only in invasive fungal sinusitis. Ketoconazole, itraconazole, posaconazole. Antibiotics, antianaerobics and mucolytics. Topical nasal steroid spray. For allergic fungal sinusitis, systemic corticosteroids like prednisolone, methylprednisolone are added for their anti-inflammatory effect. Bronchodilators and expectorants help to clear secretions in the sinuses. Surgical debridement helps by slowing progression of disease, thus allowing time for recovery and reduces fungal load. Give low-dose prednisolone 0.5 mg/kg alternate day in tapering dose for 3 months. Pre- and post-surgery, amphotericin. Epidemiology. Though it is widely held that fungal infections of the nose and paranasal sinuses are not common, most agree that their frequency has been increasing over past 2 decades. The incidence of fungal sinusitis is previously reported to be approximately 10% of all patients requiring surgery of the nose and sinuses. This alone is an increase in what had been previously suspected. A sinus is a hollow, air-filled cavity. For the purposes of this article, a sinus will refer to those hollow cavities that are in the skull and connected to the nasal airway by a narrow hole in the bone, ostium. Normally all sinuses are open to the nasal airway through an ostium. Humans have 4 pair of these cavities, each referred to as the frontal sinus, in forehead; maxillary sinus, behind cheeks; ethmoid sinuses, between the eyes, and sphenoid sinus, deep behind the ethmoids. The 4 pair of sinuses are often described as a unit and termed the paranasal sinuses. The cells of the inner lining of each sinus are mucus-secreting cells, epithelial cells and some cells that are part of the immune system, macrophages, lymphocytes, and eosinophils. Functions of the sinuses include humidifying and warming inspired air, insulation of surrounding structures, eyes, nerves, increasing voice resonance, and as buffers against facial trauma. The sinuses decrease the weight of the skull. If the inflammation hinders the clearance of mucus or blocks the natural ostium, the inflammation may progress into a bacterial infection.